Well, while some of the participants are still trying to log on, we'll go ahead and get started. So good morning and welcome to day 3 of our HFMA Colorado Virtual Summit. I'm Tammy Rivera, your Colorado HFMA Program Chair for the current year. Before we get started, and as we have for the past 2 days, we just want to take a moment to again recognize our annual business partners who not only provide financial support to our chapter, but also share their knowledge and expertise through presentations and other value-add content. While we all continue to navigate this ever-changing landscape, their support allows us to operate our chapter and bring value-add content and quality education to our members. Please consider our sponsors first when your organization is looking for services or support. So let's start with our platinum sponsors: Athena Health, BC Services, Collection Center Inc., Continuum, Patient Co., PFC, PFS Group, Revenue Enterprises, TransUnion, and WHA. Thanks so much to our platinum sponsors. To our gold sponsors, Accureg, BKD, Clifton Larson Allen, Credit Service Company, Healthcare IP, KeyBank, Plant Moran, and Guidehouse. Thank you for your support. To our silver sponsors, AppRev, Bessler, Brownstein Hyatt Farber Schreck, Colorado Health Facilities Authority, Coronis, Crossroads Health, Cyber Science, Hall Render, Parahealthcare Analytics, Strata Decision Technology, and Extend Healthcare. Thank you for all you continue to do for our chapter. And finally, our 2020 virtual sponsor, Commerce Healthcare. For today's webinar, we'll be using the Q&A box located at the bottom right of your screen, and the questions will be answered at the end of the presentation. A link to the presentation will be provided in the chat box, as well as sent via email after the webinar. For those of you who are requesting NASBA CPE credits, please take note of this keyword, leaves, because you'll need that to complete polling questions throughout this session. And there's going to be a total of 3 required polling questions to get your NASBA credit. So without further ado, let's get started with our morning session. So this morning session is going to be federal rural health policy, what's been done and what's to come. And that seems like a loaded question. We have here today with us our friend John Supplett, the Senior Director of AHA Rural Health Services. He is a Senior Director of the Center for Rural Health Services of the American Hospital Association. Since 1993, he has worked to identify, develop, and advance the unique healthcare interests, issues, and perspectives of rural hospitals. He has served on several national panels and advisory groups for development of national rural health policy, program development, and demonstrations, grant review, and evaluation as well. Mr. Supplett, I'm going to turn the mic over to you. Thank you so much for being here.
Great. And I'm going to share my screen. How's that? You got it? All right, great, good. All right, well, thanks everyone for having me. It's great to be participating in your program this fall and to be back again to join you. It's really important that we meet, whether it's virtually or in person, so that we can maintain our relationships and have conversations about our activities and our priorities. So thanks for doing that. This is a rural advocacy and policy federal update, and we'll touch on a number of things. This is how I'm going to approach our agenda. We're going to talk about how we're paid, and this should be a review for most, but I think it's an important review so that we are coming off from the same page. I'll have an advocacy update, which is all of 2 slides, and that's because advocacy is clearly a little bit tricky coming into what is the lame duck session, but prior to that as well, given all the activity on the Hill. We'll talk about then policy, and policy has been very dynamic with the president's various executive orders, additional CMS rulemaking, and the other regulatory activity that we're expected to be on top of all along. So let's begin with a review of these old models of payment and delivery. And why are we doing this? Well, first, so that we have a shared understanding of how we're paid and how that has evolved over time. And secondly, so we appreciate how these models have become outdated and no longer align with current or future models of delivery. So what are these old models of payment and delivery that no longer serve the needs of healthcare providers? Well, to review, in 1982, the Healthcare Financing Administration, or HFMA, transitioned from paying hospitals based on their reported costs to paying a prospectively set amount on a DRG, a beneficiary's diagnosis, and this is the inpatient PPS system. And as you can see from this flow chart, the base operating payment or standardized amount for inpatient services includes a labor and non-labor related share. And the labor-related share is adjusted by a wage index to reflect area differences in the cost of labor. And these rates can then be adjusted upward for teaching, disproportionate share, whether it's Medicare or Medicaid, new technologies or high cost outliers. And they can also be adjusted downward for meaningful use of electronic health records, value-based purchasing incentives, readmissions, and hospital-acquired conditions. And all of these adjustments are now points of contention regarding the fairness of this payment model. And similar to the operating amount, the inpatient PPS capital payment begins with the base rate that's adjusted by the wage index, cost of living, and other geographic factors. And like the operating amount, the capital payment may be adjusted upwards for disproportionate share and indirect medical education. Now, the fundamental flaw in this method is that payments are determined from historical costs. That is, if you were a low-cost hospital, then you're being punished for being efficient in perpetuity. Ultimately, for most small rural hospitals, the Medicare payments they received under PPS were not sufficient, resulting in increased financial distress and even closures. And in response, Congress created rural payment designations that, among other things, can provide hospitals with additional payments on top of what CMS pays through the inpatient PPS. So CMS now recognizes 5 Medicare rural payment designations, and the first of which is critical access hospitals, which were legislated by the Balanced Budget Act, but was really built on demonstrations from Montana's medical assistance facilities, and then part of the CMS Essential Access Community Hospital and Rural Primary Care, or EACH-PEACH programs. And if a hospital's eligible, and you can see the eligibility on the slide, then critical access hospitals are paid for most inpatient and outpatient services at 101% of allowable costs, less 2% for sequestration. Critical access hospitals are subject to Medicare Part A and Part B deductible and coinsurance amounts, which is 20% of applicable Part B charges, which is a point of contention that we have to manage all the time. A critical access hospital can be paid costs for its ambulance transports under certain conditions, primarily that you're 35 miles from the next nearest provider. So community hospitals can receive operating payments based upon the higher of their hospital's specific payment rate or the federal rate, while their capital payments are paid based on the capital-based payment rate like all other PPS hospitals. For this program, a hospital service area is the area from which it draws at least 75% of its inpatients. There are a couple more. The third category is Medicare dependent hospitals, which was established by the Omnibus Budget Reconciliation Act of 1989. And it was intended to only last for 3 years, but as we know, it's been reauthorized dozens of times since then. And if eligibility, and again, you can see the eligibility on the slide, Medicare dependent hospitals can receive operating payments based on the higher of the federal rate or a blend of the federal rate and their hospital specific payment rate. Capital payments, again, are solely based on the capital based rate for PPS. And Medicare dependent hospitals may also qualify for a payment adjustment if they experience a significant volume decrease. The Rural Referral Center program was established to support high volume rural hospitals. Eligibility criteria on the slide are very complicated, but in general, an acute care hospital is classified as a rural referral center if it's located in a rural hospital and has 275 more beds, and at least 60% of the hospital's Medicare patients live more than 25 miles from the hospital. And then this fifth payment type, considered as an exception by CMS, is low volume hospitals. And CMS applies the low volume adjustment using a continuous linear sliding scale ranging from an additional 25% payment adjustment for hospitals with 500 or fewer beds, or discharges, excuse me, to 0% additional payment for hospitals with more than 3,800 total discharges in their fiscal year. And on this pie chart, you can see a breakdown of rural hospitals by payment type, but note that here, critical access hospitals are rural only. There are about 80 urban critical access hospitals. And what I find of special interest is the 145 tweeners, those that are rural hospitals that are paid under PPS, of which 88 get the low volume adjustment, but 57 are true tweeners. They are strictly paid under inpatient prospective payment. So to summarize, there's currently 5 Medicare rural payment designations: critical access, sole community, Medicare dependent, rural referral, and then low volume. And all of them have convoluted eligibility and payment criteria designed to solve a problem at a moment in time, but have been extended over decades as an attempt to stabilize the rural healthcare delivery system. So with that as background, let's discuss our efforts to influence how rural hospitals are regulated under Medicare. And I'll begin with an action alert that we have been sending out to members for the past few days. And we've been very aggressive regarding action on reporting costs under the public health emergency. We've asked members to ask their representatives to sign on to these Dear Colleague letters that were basically looking at reporting requirements and the definition of expenses and lost revenues attributable to COVID-19. That is, lost revenue was any revenue that healthcare provider could lost during COVID-19 and should be replaced by those outlined in the September 19th notice. Well, we learned yesterday that HHS is reversing its position on this definition for lost revenue. That is, it's amending its reporting instructions to provide for the full applicability of provider relief fund distributions to lost revenues without limitations as originally suggested on June 19th. And I'll drill down this in much greater detail when I get into the regulatory policy discussions. Regarding advocacy opportunities for this Congress, throughout the year, signs have pointed to real interest and a potential opening. But of course, things have become immensely complicated due to COVID-19 legislation, as well as arguments over the federal fiscal year budget and continuing resolutions. Nevertheless, we think that there's a potential for this to move forward as part of the budget reconciliation for the balance of the fiscal year when continuing resolution expires on December 11th. So that will be our window of opportunity if we're going to make something happen. And what's included in this rural package then is the Rural Hospital Closure Relief Act, which would reopen the necessary provider designation for critical access hospitals for state designation. It would renew for 5 years the Frontier Community Health Integration Extension, which tests new models of healthcare delivery for critical access hospitals in the most sparsely populated states. It would extend the Rural Community Hospital Program that tests reasonable cost reimbursement for inpatient services, including swing beds, in rural hospitals that have fewer than 51 acute care beds and wouldn't otherwise qualify for critical access. It would permanently remove the 96-hour physician condition of payment for critical access hospitals. And it would expand the J-1 visa program to 35 foreign physicians per year to health professional shortage and medically underserved areas, and allow a reallocation of slots if states don't use their allotments. It would pass the Opioid Workforce Act to address existing shortages in behavioral and substance abuse, clinical care and treatment by adding 100 1,000 Medicare-funded training positions and approved residency programs. It would pass the Healthcare Workforce Resilience Act, which would make previously unused immigrant visas available to nurses and physicians for up to 90 days after the end of the national public health emergency. And it would also include additional funding for expanding broadband and telehealth services. Again, the last chance for this action will be after the election and with legislation to extend the federal budget that expires on December 11th. So from a policy perspective, this has been a very dynamic year, beginning with the blanket waivers that were implemented in March upon declaration of the national public health emergency. And then more recently, we've seen additional efforts come forward through another executive order from President Trump. And I'll spend some time reviewing these with you. The March waivers included considerable regulatory flexibility and waivers on a variety of ways. And as you can see here on this slide, for critical access hospitals, it dealt with the 25 bed limit, the 96-hour length of stay, rural location. In other words, and this is an issue in many states, if you're a critical access hospital that was designated by the governor, but you're in an urban area, CMS was reviewing your eligibility to participate. So that became part of these waivers, as well as state law for staff licensure and remote physician supervision. For rural health clinics and FQHCs, again, supervision and staffing flexibilities for physicians, service location expansion, increase in bed capacity for rural hospitals with RHCs without any impact to payment. Again, for sole community, Medicare dependent, bed capacity and distance, bed capacity and market share. For post-acute cares, a waiver of the 3-day stay for SNF eligibility, a renewed SNF coverage without having to renew the benefit. Acute care hospitals can offer swing beds that would be paid at the SNF rate. And then for workforce out-of-state providers and nurse practitioner practice flexibilities. These are huge steps forward in terms of flexibility that all of us embraced and have been glad to see continued throughout the course of the national public health emergency. And I think among the biggest of these waivers was those that were related to telehealth. And when CMS expanded access to include the provision of E&M services via audio-only phones, to allow practitioners to render telehealth services from their homes, paying for more than 80 additional services when furnished via telehealth, including emergency department visits, allowing virtual check-ins with physicians to be provided to new as well as established patients, and then allowing clinicians to provide remote patient monitoring services for acute conditions, whether they're COVID-19 related or not, and allowing telehealth to fulfill many face-to-face visit requirements for patients in inpatient rehab, home health, or hospital, and much more. So again, these waivers were enormous in terms of our ability to manage and treat patients under COVID-19. And as we see states continue to experience surges at a proportion that is greater than any we've seen during the course of this pandemic, these waivers become and are increasingly more important. The second executive order occurred on August 3rd, when the White House issued its executive order on improving rural health and telehealth access. And the order includes directives to launch a new payment model for rural health care, to develop and implement a strategy to improve rural healthcare infrastructure, to create a report describing policy initiatives to improve rural health, and to propose regulation that would extend certain telehealth flexibilities. And in response to this executive order, HHS, the Department of Health and Human Services, published its Rural Action Plan, which included the Secretary's 4-point strategy to transform rural health and human services, which builds on its initiatives to build a sustainable health model for rural communities, to leverage technology and innovation, to focus on preventing disease and mortality, and the fourth is to increase rural access to care. Also, in response to this executive order, the Federal Communications Commission, HHS, and the U.S. Department of Agriculture signed a memorandum of understanding to establish an interagency rural telehealth initiative task force to consider future recommendations or guidelines for this effort and to exchange agency expertise, scientific and technical information, data, and publications. The Community Health Access and Rural Transformation Model, or the CHART model, also is an extension of the HHS's Rural Action Plan and the President's executive order. And through CHART, CMS aims to continue to address disparities by providing a way for rural communities to transform their healthcare delivery system through capitated payments and operational and regulatory flexibilities. The CHART model includes the following two tracks: the Community Transformation Track and the Accountable Care Organization Transformation Track. And CMS is going to have a webinar during their office hour next Tuesday. So if you're interested in this, you might want to register for that. Community transformation plans are detailed descriptions that outline the community's plans to implement a healthcare delivery redesign strategy. And you can see where the emphasis is being placed on community strategies. Lead organizations will be responsible for the development and implementation of transformation plans with their community partners. Participant hospitals will receive predictable capitated payment amounts that is prospectively set each year, and Medicaid alignment with these capitated amounts is required. The timeline, and you can see it on the slide, for applications for this track will be available in September. The notice the notice has been out. CMS will select up to 15 rural communities to participate, with the winners being announced by early 2021, and then the model starting in the summer of 2021. The second track, or the ACO transformation track, the hallmark is the advanced shared savings payments that CMS will pay to participate to help offset those upfront costs of implementing value-based payment models. And the timeline for this track is in spring of 2021, with this track launching in January of 2022. And looking at both tracks in greater detail, beginning with the community transformation track, CMS will select 15 lead organizations to participate. The lead organization is the entity that represents a rural community. Examples would include state Medicaid agencies, state offices of rural health, state hospital associations, local public health departments, independent practice associations, and academic medical centers. Lead organizations will receive up to $5 million. They're responsible for managing funding, recruiting participant hospitals, engaging the state Medicaid agency, establishing relationships with other aligned providers, convening an advisory council, and ensuring compliance. Participants may be rural acute care hospitals, critical access hospitals, or special rural designation hospitals that sign a participation agreement with CMS. The community transformation track includes waivers. For example, participants will be permitted to waive cost sharing for Part B services, provide beneficiaries with transportation, and offer incentives for chronic disease management programs. Additional flexibilities include waiver of the requirement for the 3-day inpatient stay prior to admission to a SNF, telehealth expansion, continued post-COVID, post-discharge home visits, care management home visits, elimination of the critical access 96-hour rule, and waiver of certain Medicare hospitals' conditions of participation. But again, the state Medicare agency is required to partner and must be a subrecipient of the cooperative agreement funding under this transformation track. On the ACO side, the CMS will provide upfront funding for ACOs, building off the success of the ACO investment model, or the AIM ACO, between 2016 and 2018, which was hugely successful for the 47 ACOs that participated. And they're going to apply the principles from that model specifically to rural organizations. CMS will select up to 20 rural-focused ACOs to join the ACO transformation track. The participants must have a majority of their suppliers and providers located within rural counties or census tracts, and for the full duration of the program, participants will be required to enroll in a two-sided level of Medicare shared savings. And the advanced payments will have two components. First, a one-time upfront payment of at least $200,000 plus $36,000 per beneficiary, and a prospective per beneficiary per month payment of at least $8 for up to 24 months. This is very similar to the AIM ACO model. Assignment will follow the Medicare Shared Savings Program methodology with up to a maximum of 10,000 beneficiaries. And while the bulk of the attention went to chart, there were other directives included in the President's executive order from August 3rd. One of which was Rural Infrastructure Investment Strategy, where the HHS and the Department of Agriculture were going to implement a strategy to improve rural health by improving the physical and communications healthcare infrastructure available to rural Americans. And the second directive included the Secretary to review within 60 days temporary measures to put in place the COVID-19 public health emergency waivers for additional telehealth services offered to Medicare beneficiaries, the services, reporting, staffing, and supervision flexibilities, and then to propose regulation to extend measures beyond the public health emergency period. So those are the policies that have come from the administration as a response to the pandemic, the executive orders in March and then in August. And these are very favorable and offer us some new options for payment and delivery. However, the administration continues to publish its regular rulemaking and has come forward with several other policies that are not quite so favorable. And I'm going to review those with you now. On August 25th, CMS introduced a new heavy-handed regulatory approach on daily reporting of COVID-19 as a Medicare condition of participation. And this disturbing move, announced in its final form, if enforced to the letter, would jeopardize access to care and leave patients and communities without vital health services from their local hospital during a pandemic. Clearly, we called on CMS to reverse this rule immediately. Nevertheless, CMS Administrator Verma told reporters on October 7th that by mid-January, hospitals that don't regularly report key information face an ultimate penalty of being kicked out of Medicare and Medicaid. And at least 2/3 of hospitals have been informed by CMS if they are in compliance with this condition of participation data reporting requirements already. And if they're not, the steps that need to be taken in order to become in compliance. Now, as a footnote, on July 29th, HHS updated its reporting guidance to offer a way for those hospitals using the teletracking reporting option to submit data from previous days, including weekends, which is very important for low volume critical access hospitals that don't staff all those departments or services on weekends and would be required to backtrack their reporting. But hospitals that wish to report this data should connect the teletracking help desk in order to arrange that reporting system. On August 26th, CMS updated its frequently asked questions on Medicare fee-for-service billing. And beginning on page 98 of those frequently asked questions under Section 5 cost reporting, is information that may be helpful with your planning on provider relief fund payments reported on the Medicare cost report. And according to the frequently asked questions document, providers should not adjust the expenses on the Medicare cost report based upon provider relief fund payments received. Similarly, the facts state that providers should not offset Small Business Administration loan forgiveness amounts against expenses unless those amounts are attributable to specific claims such as payments to the uninsured. And the guidance also directs providers to report provider relief fund payments and Small Business Administration loan forgiveness on the cost report statements of revenues for informational purposes. And then it provides further instruction on how to report the funds on cost report worksheets. Well, on September 19th, CMS updated its reporting guidance on the use of funds. And then yesterday, this guidance was revised. That is effective yesterday. HHS has reversed its position. That is, it will allow a provider to apply provider relief fund payments against all lost revenues without limitation. And recipients will report the use of these provider relief fund payments by submitting the following information. First, healthcare-related expenses attributable to coronavirus that another source wouldn't reimburse or is not obligated to reimburse. And then provider relief fund payment amounts not fully expended on healthcare-related expenses attributed to COVID-19. And then are applied to patient care lost revenues net of healthcare-related expenses attributable to COVID-19. Recipients may apply provider relief fund payments towards lost revenue up to the amount of the difference between their 2019 and 2020 actual patient care revenue. And in fact, there's other flexibilities there as well. But the issue was between the June and September was the definition of lost revenue. And we know this threatens a material loss to critical access hospitals and some small inpatient PPS. We're pleased to report that our advocacy efforts were successful, at least in part, but we're continuing to review this guidance, particularly for its impact on critical access hospitals. On a positive note, HHS on October 5th opened the application process for the $20 billion in funds from the Provider Relief Fund. Under this third general distribution, hospitals and other providers can apply for additional payments that consider COVID-19 related financial losses and changes in operating expenses. HHS has outlined the following methodology. Any providers that have not yet received relief fund payments equal to at least 2% of patient care revenue will receive a payment that, when combined with prior payments, equals 2% of patient care revenue. Using any remaining balance of funds, then HHS says they will make an equitable add-on payment with the following considerations: changes in operating revenues from patient care, changes in operating expenses from patient care, including incurred expenses related to COVID, as well as payments already received through distribution of PRF. And we're pleased to report that effective yesterday, HHS has expanded the list of providers across a broad category of practices. And among those it cites are hospital units, behavioral health providers, hospital providers, labs, and ambulatory healthcare facilities. The application period for this general distribution is open through November 6th. And more favorable news includes an announcement on October 8th regarding new repayment terms for payments received under the accelerated and advanced payment programs, including a longer time period before repayment, lower recoupment rates during repayment, lower interest on remaining unpaid balance, and then additional repayment flexibilities. However, on October 9th, the next day, the department published a frequently asked question and then corrected an error explaining that providers cannot use COVID-19 provider relief fund distributions to repay payments made under the CMS accelerated and advanced payment program. Let me pause there. There is one question, or there was one in Q&A, and it seems to have been taken down, which is fine. No worries there. It's a little hard going back and forth. So I'll continue through the presentation and we can have a discussion at the end, time permitting. So that takes us to regulations, and much of what I've covered has transpired in the summer and early fall has to do with the national public health emergency during the COVID-19 pandemic. However, regular rulemaking continues with which we're expected to comply. And first, CMS issued new requirements for the DRG add-on on August 17th. They updated the guidance related to the 20% inpatient PPS DRG add-on for patients diagnosed with COVID. The inpatient admissions occurring on or after September 1st, claims eligible for the 20% add-on have to have a positive COVID-19 lab test document. Then on September 3rd, CMS released its final rule for inpatient PPS, which was effective October 1st. The rule increased Medicare inpatient PPS rates by a net of 2.9% for the fiscal year for hospitals that are meaningful users and submit quality measure data. The hardship exception is available, but is due in November. In addition, the rule makes changes to disproportionate share hospital payments, CAR-T therapy payments, and quality of incentive programs. And CMS finalized a policy to require hospitals to report payer-specific negotiated rates for inpatient services by Medicare severity diagnosis related groups for Medicare Advantage organizations. And this policy, this transparency policy, will be in effect for cost reporting periods ending January 1st of 2021. So it's in effect of January 1st of 2020. We don't believe CMS has the authority to compel the disclosure, and our legal challenges have been ongoing, but I'll touch base on that in a second. And as a footnote, we have created a calculator to help member hospitals estimate the dollar amount of the impact of the final rule. On August 4th, CMS released the calendar year 21 outpatient PPS proposed rule. And in addition to the standard updates, the rule would continue site neutral payments at ambulatory surgical center rates or office visit rates. It would further reduce the payment rate for certain drugs purchased under the 340B program. It would expand the list of outpatient services subject to prior authorization. It would eliminate the inpatient only list. It would make significant changes to the hospital star ratings methodology. And it would also change the physician-owned hospital policy. On October 5th, we submitted our comments and continue our opposition to any payment cuts made to 340B hospitals. Again, we don't think that the HHS has the legal authority to do this, and we've been challenging it in the courts consistently. We also strongly oppose the rule's proposal to eliminate the inpatient-only list, to remove certain restrictions on physician-owned hospitals that qualify as high Medicaid facilities, and the change to the ASC covered procedures list. We did applaud CMS for its proposed changes to the hospital overall star ratings. And then on August 3rd, CMS issued a proposed rule that would update the physician fee schedule payments for the calendar year. We are pleased that the agency includes several proposals that would increase telehealth as well as scope of practice flexibilities. We also appreciate the flexibility in the opioid treatment program benefit and the delay in the clinical lab fee schedule data reporting period. But we are concerned about the redistributive effect of CMS's budget neutral proposed increases in payment rates for office outpatient evaluation and management visits. And as mentioned in the outpatient proposed rule, CMS continues in an appeals court upheld the cuts to 340B at average wholesale price minus 29%, which is about 39%. Exemptions continue for critical access hospitals, but we litigated through an appeal. Unfortunately, the full U.S. Court of Appeals for the District of Columbia denied our request to consider two decisions. That happened on October 16th. Two decisions, and one of which is to cut the payments for 340B drugs, and the second was to refuse to hear site neutral or off-campus outpatient clinic visit payments. So we're weighing our options, but it appears that these battles are going to be lost. On another matter, in July, we sent a letter urging the Department of Health and Services to direct HRSA to take action to stop drug companies from limiting the distribution of 340B drugs to covered entities, including contract pharmacies. Then on August 21st, we sent letters to the heads of the US operations for 5 drug companies that were guilty of this: Merck, Eli Lilly, Sanofi, Novartis, and AstraZeneca, expressing our profound concern over actions that they're taking to limit the distribution of 340B drugs to hospitals and systems during the height of a pandemic and asking them to cease this conduct immediately. On October 15th, a federal appeals court in Washington heard our oral arguments with respect to the price transparency update to overturn HHS's rule requiring disclosure of confidentially privately negotiated rates with insurers. As mentioned, the lower court previously upheld this rule. We didn't get a ruling yet, but we did conclude by urging the court to decide the appeal quickly because of the looming January 1st compliance deadline and the unreasonable burden it places on the hospital field. Many of our rural hospitals will not be able to tool up in time to meet this requirement effective January 1st. And so that is a point of contention, at least for a delay. The AHA has been actively engaged in identifying and promoting best practices in private patient billing for the past 2 decades. And on October 15th, we released updated voluntary guidelines on patient billing. And these voluntary guidelines represent what a hospital and health system can and should do to address issues of coverage, billing, debt collection, and accountability. Now, the guidelines are largely adapted from what is already required in federal law for tax-exempt hospitals and are intended to align with the core principle of universal coverage. Specifically, all individuals should have access to and ensure they are enrolled in a form of comprehensive health coverage as a primary mechanism for paying for care. Then on September 24th, the Department of Homeland Security has announced a proposed rule to require a fixed period of stay for international students, exchange visitors, and others in an attempt to encourage program compliance, reduce fraud, and enhance national security, which is a bit of an overkill. So we joined 5 other national medical groups, which you can see on the header of this slide, in urging Homeland Security to exclude foreign national physicians in the J-1 visa program. Because by placing a hard stop on 4-year visas, the impact could reduce physician training and even approve stays by up to 2 years. The change in this duration of status model would add no value to the J-1 physician cohort, and instead it would jeopardize the delivery of patient care in the United States. The patients who would be most impacted by those are in underserved and rural areas and those living in critical access points in large cities. In addition, other trainees in those programs would have their education and training negatively impacted as the workload shifts from those who are leaving to those that remain as a result of the loss of J-1 visa trainees. And to make matters worse, this occurs during one of the worst pandemics in our nation's history and in the face of projected long-term physician shortages. And I'll finish with a reminder on the Federal Reserve's Main Street Lending Program. It's designed to help small and medium-sized for-profit businesses and nonprofit organizations credit flow, particularly those that were in sound financial condition prior to the COVID-19 public health emergency. And under the Main Street Lending Program, the Federal Reserve purchases 95% of each loan's debt issued by eligible lenders, with the lender retaining the remaining 5%. And borrowers pay no interest until the loan's second year and no principal until year 3. The program requires lenders to evaluate borrowers' financial condition and creditworthiness based upon the terms of the Main Street program and then the lender's own underwriting standards. The Federal Reserve had a webinar on this on October 21st, which was Tuesday or Wednesday. And I'm sure that there's a recording of that for those who are interested and want to pursue participating in the Main Street Lending Program. So that brings me to the end of my presentation. I've opened up the Q&A box as well, but we'll be glad to take any questions that you might have.
Thanks, John. I'm not seeing anything in the Q&A or the chat right now. Feel free to use either one of those to submit a question if you have one. We can also use the raise your hand function. If anyone has a question and I can unmute you, you can ask your question in person. I do see we have one attendee with their hand raised. Stella, I don't know if you know that you have your hand raised or if you have a question. It's been up for a minute.
Well, while you're figuring that out.
Hey, Stella, if you can hear us, and let us know if you have a question. I've got you unmuted, I believe.
Oh, somebody's asking, am I unmuted? Can you hear me?
We can hear you, John.
Okay, somebody's asking about the UHC and the lab registry. That was a discussion that we've had in the past. I don't have new information to share on that. I don't know where it was being implemented. I really don't have an answer to your question on the UHC and the lab registry. Sorry for that.
All right, well, barring any additional questions coming in, I will just take this time very quickly to remind all of you who are here, if you are a member of HFMA or are considering becoming a member of HFMA, I want to remind you that the membership now is all inclusive and includes your certification. So if you're a member and you've considered getting certified in the past, but price was an obstacle of any sort, it is completely included in your membership now. You can complete it online on your own time. So reach out to the chapter if you're interested in finding out more about that.
Tammy, you had asked about in the question box about expanding on the initial thoughts of the public relief fund guidance. And the initial thoughts are, we need more clarification. I have not personally drilled down into the details of what was released. It is substantial, and it does merit a deeper dive. We're not entirely comfortable that it addressed all the challenges that you would be confronted with, particularly as a critical access hospital in a year-over-year comparison in terms of lost revenues. So we'll take a look at that. What was absolutely fascinating about this experience is that we had circulated dear colleague letters in both the House and the Senate almost immediately after that September 19th guidance came out, with the intention of getting them to revert back to the June guidance. And they actually responded, CMS actually responded with their change in guidance the day before the sign-on for the Senate letter had closed. So clearly they're hearing from a number of sources with respect to the guidance on provider relief fund reporting. And I imagine that they still are attuned to that, but whether or not, or how they will move forward after this October 22nd update remains to be seen.
Thank you, John. Well, I think we can maybe give everybody a little break now between this and our next session, since it doesn't appear that there are any more questions. I want to thank you so much for your time today, John, and thank you to everyone who joined us today. We look forward to seeing most of you in the next session, which is the Colorado Hospital Association update.
Great, thanks everyone. It's great to be participating in your spring fall conference.